also the rated examination of the proximal joints.
All right. So he's got a bit of a Galeazzi sign on his right side, which is a bit lower, and it's completely reducible.
Yeah.
Do you want to
Yeah.
ask him to take off his pants? He's got a...
I think they can see it. You can see he's telescoping, and he has a
Let's
positive.
turn him around for them to see.
All right.
And can you project that on the screen? The telescoping sign? Camera?
So let's look at the good side first.
Can you show this?
So the good
No,
side,
let's
basically, he is
let's get him.
stable on the.
No, I don't need. Just let's get him this way so that the camera person can show that on the screen.
Which way? Sorry.
No, turn him
No,
around.
no, it's fine. It's fine. Now you just do the same thing. ये camera ये दिखाइए on the screen.
He has a slight subluxation. He has a slight subluxation, but it's not a full dislocation, I don't think.
But this side,
And this side, on the other hand,
turn him around, then it's, they can't see. Sorry, Betty.
ऐसे वो आता है ऊपर सर.
Yeah.
तुला पण
so
chocolate
this
मिळणार.
side, that's in, and that's out. That's in, that's out. And it's not painful. So he has a dislocating hip on the side and a subluxating hip on the left. I would probably say that he's better off with the subluxation on the left. The rule of the thumb in Milo kids with the hips is this. In ambulatory kids with bilateral dislocation, in non-ambulatory kids with bilateral dislocation, you don't touch them. All right? Ambulatory kids with a unilateral dislocation, you might do something about. Non-ambulatory kids with you won't touch a bilateral dislocation. The question is about a unilateral dislocation. Remember, if you have a bilateral dislocation in an ambulator, probably the worst service you can do is try to attempt to relocate the hip, be successful on one side and unsuccessful on the other side. And then you put him into an imbalance. The boy is painless. I would think quite a few times before I attempted to relocate. I mean, we can relocate it. The problem is retention, and there are ways to do. There are muscle transfers. There's a Linsen transfer. You could do a Chiari. You can do a lot of things here. But this is a very mobile and painless hip, which gives him a leg length discrepancy of, say, 2 centimeters, which can be treated with a shoe lift. So my tendency would be not to attempt to relocate this hip. If it becomes symptomatic, and some of them do, then the story changes a bit. But as long as he's symptomatic, this dislocating hip will give him a bit of a limp. It won't prevent him from walking. And if you get him in and give him a stiff, painful hip, you did him very poor service. So I think, I'll be glad to open it for discussion, but that would be my. And the main thing would be to keep it, he's insensating the foot. And that's probably the most problematic part, because these callosities can become ulcers, can become infected, and then we start a bad path. So I would be very, very attentive to his skin condition. And I think with good bracing, he'll definitely be able to continue to be an ambulator. So I think that's the way I would do. I don't think there's anything surgical which has to be done. There's no deformity. The foot is completely supple. He can walk
Just
flat.
few shoe slides.
That can be kept.
Don't say anything special about the bracing.
Orthosis. That's the route I've gone.
What kind of brace would you suggest for him? Fixed ankle?
Pardon?
What kind of a brace would you suggest for him?
No, well, yes, a fixed ankle, because
Fixed ankle.
I don't think that he has no ankle motion, so there's nothing to be gained by giving him.
No dorsiflexor, no plantar flexus, no fixed
It's
ankle.
more cumbersome. I would start off. I don't think he needs an KFO, and I don't
Good
think
quadriceps.
an HKFO. I think you can go beneath the hip. I would probably start off with a hinge which can be locked and unlocked. But with time and with therapy, you might be able to get away with an AFO below the knee eventually.
Anybody out there who has a hunch on his gluteus maximus power? Anybody can suggest?
Any comments from anybody?
He doesn't have a flexion deformity of the knee, right?
No.
Yeah, he stands with an orthotic aid.
He doesn't have the orthosis here.
His knee and lock it, then maybe
Just
you
give
don't
him
need
a
a AFO, right? If he can lock his knee in extension.
Well, he's weak. He's weak. I would start off, I'd start off with a KFO, and you can always, plus, no, he's stable mediolaterally, which is another thing you have to check, which sometimes they're not. And you have to look at, you probably need a shoe lift on the right side because
Has the shoe raise.
A shoe raise.
He's having an KFO, which he locks into.
Right.
Hinge he locks.
That's correct. Because when he goes into recovery, we don't need KFO. The quadriceps is good. I think we'll have to stop. We're already exceeding the time. Thank you. Any questions? Quick.
Thank you very much.
One question.
Thank you.
Can you just quickly switch? I'll just add 2-3 points and know we're exceeding the time.
Yeah.
Can you get the computer on?
Bring. All right. Yeah, good. So not. No, I couldn't badmouth everybody yet.
Polio, fortunately, is less common as you go south of India. And this year we've had no new cases so far, so which is a good sign. The reason I showed these few slides is just to tell some of the deformities which you may not know. How many of you know what is a dorsal bunion? Dorsal bunion. That's how it looks. Yeah. When the first metatarsal is raised, and the reasons for this can be either because the tibialis anterior is strong and peroneus longus is weak, only then, because tibialis anterior is balanced by peroneus longus. Or you have weak dorsiflexors acting against strong plantar flexors. So the dorsal bunion must be recognized as a deformity. You have it in some of these patients. So a lot of people do not know what is a dorsal bunion. That's why I showed this picture. This is a clawing. You need to differentiate between two types of clawing: swing phase clawing and stance phase clawing. Swing phase clawing because of tibialis anterior weakness, because extensor hallucis comes to help out. And stance phase clawing, that's an equinus with corrections. And stance phase clawing happens when the patient has got a calcaneus deformity. Stance phase clawing when the other long toe flexors are roped in to substitute for the function of the tendoachilles. That's stance phase clawing. So I just wanted to highlight these 2-3 points, because otherwise I'm already exceeding time. But these 2-3 points, people, when they're examining, they don't understand too well. And the calcaneus deformity must be recognized as a significant deformity. And the heel, when you're examining, don't forget to examine front, side, back and inner side. All 365 degrees of the foot must be examined. And the heel in an equinus foot is small. Heel in a calcaneus foot is large. So you need to know the differences between clinical examination. Sometimes there is a confusion. Tendoachilles is not functioning because of gravity. There is equinus, and you tend to say that because tendoachilles is not functioning, you call it a calcaneus. So please look at a calcaneus, true calcaneus foot. The heel will be prominent because every time the foot is striking the ground, the heel is striking only, the forefoot is not touching. And the reverse happens in an equinus foot. Heel is small and it is not developed properly. So I'll just stop here. 2-3 points to highlight in the examination of a foot. Thank you very much.
Good afternoon, everybody. Genuvarum and valgum are the commonest knee deformities in children. When a child with bow legs or knock knees walks into your OPD, you must think of varied etiologies, starting, of course, with physiological varus and valgus. Different types of dysplasias give rise to these deformities. Metabolic disorder like rickets, you should rule that out. And of course, generalized bone disorders should be checked for. Congenital deformities of tibia and femur usually give rise to unilateral genuvarum or valgum. Asymmetric physial growth, either deceleration or stimulation, can lead to genuvarum or valgum. For example, metaphyseal fracture of proximal tibia leads to genuvalgum. Long bone malunions, Blount's, and post-polio deformities are some more causes. Before going into the physical examination, you must inquire about the duration and evolution of the deformity in details. Family history is very important. History of infection, injury, presence of pain, functional impairment, and history suggestive of systemic disorder should be asked for. Coming to the physical examination, gait, of course, is very important. Standing lower limb alignment. In this, we check for measurement of varus and valgus, and we do a rotational profile, because very commonly rotation is associated with genuvarum and valgum. So you must check for the rotational deformities. Then we go for joint range of motion and stability. Laxity of the ligaments should be checked for. Limb length discrepancy, if it is there, should be measured. Neurological status. A thorough examination of hip and spine and a general examination should be carried out. Before going into the physical examination in details, a few words about radiology. Orthoradiogram is a full-length X-ray taken from hip to ankle on a long film at a distance of 10 feet, and the patient stands with patella facing forward in a single exposure. So this X-ray is very important not only to diagnose the deformities but for doing pre-operative planning. Specific views are taken as and when needed. This is the normal lower limb alignment in an adult. Okay, so mechanical axis and anatomical axis of femur and tibia make specific angles with joint orientation lines of hip, knee, and ankle. And if these angles are changed, any deviation from these normal angles suggests that there is a deformity. I think Dr. Sabrawal will be talking in details about planning, so I won't go into the detail. This normal alignment is attained in a child at the age of 7 years. Okay? So below the age of 7 years, these angles are different. They are age specific. You can refer to Dr. Sabrawal's original article in JPO. There you will find age-specific angles. So below the age of 7, if you want to do preoperative planning, please use age-specific angles. Okay, now we come to the physical examination. We come to the gait. There are different types of gaits which are found with genuvarum and valgum. This is commonly a found gait. What gait is this? Yes, it's an in-toeing gait. In-toeing gait can be found with internal tibial torsion, whenever there is excessive anteversion, whenever there is femoral shaft torsion, and even a forefoot adduction can mimic in-toeing gait. Look at this girl, she has severe genuvarum, and she is walking with what is called as lateral thrust. Can you appreciate that? Okay, that is suggestive of lateral collateral laxity. And this girl is walking with genuvalgum. She has hips in adduction, the hips go in adduction because of valgum, and they walk in slight circumduction for clearance. In lower limb alignment, what do we see? We see measurement of varus and valgus. Clinically, how do we see that varus and valgus? We measure the intermalleolar distance when knees are touching each other, and we see the distance between the knees when the ankles are touching each other. These distances are useful to monitor the progress of the deformity clinically in subsequent follow-ups. So this is how you measure the distance between the knees. Intermalleolar distance more than 15 is usually pathological. How do you do torsional profile? You check for 4 things: gait progression, hip rotation, thigh foot angle, and foot border profile. Okay, I think many speakers have talked about gait progression and foot progression angle. As in this case, there is an in-toeing gait, so the foot progression angle is negative. Normally, it is either neutral or slightly positive. Hip rotation, typically increased internal rotation and reduced external rotation is suggestive of excessive anteversion. Okay? These kids usually sit in W position